With Sanwen Tu from Shanghai Jiao Tong University in China, and he will speak on tissue classification and novel AI-assisted methods to assess plaque vulnerability. Please.
Thank you. So I would like to thank the organizer for inviting me back to Netherlands. I used to study and work in Netherlands for 6.5 years before moving back to China and working at the Jiao Tong University. So this is my disclosure. So OCT enables detailed plaque categorization, but visual estimation is subjective. So we try to use AI to see whether we can standardize this image interpretation. So we create the deep learning model based on the annotation data from 509 OCT pullback. So the model is capable of integrate consecutive OCT slice information to automatically label the plaque composition and also some vascular structure like side branch or guide wire as shown in the figure way. So for the validation, so we perform the external validation. So we invite three collab are very experienced in the OCT reading. One is CIF, the other one is the Aarhus University Hospital, and the other one is the Harbin University Hospital in China. So 3 continents. And so basically what they do is that they independently label 300 image frame from 30 pullback with different feature, and so we have 3 situations. One is 3 collab all agree, and the other one is 2 collab agree, 1 disagree, and the last one is the all 3 collab disagree each other. Like we use the majority voting, and if 2 collab agree, then we set them as the consensus data for the validation of the AI. So the lower image shows you the inter-collab agreement. As you can see that in about 99% we could reach consensus, like only 80.8% 3 collab all agree. And this is the highest agreement is highest for crystal, crystal, the lowest for the lipidic burden, lipidic plaque. So using the consensus result as reference standard, we found out that the AI model has a mean accuracy of 92.2% for the 3 basic plaque composition, including fibrous, lipid, and calcium. The AI performed the best. It's still in the cholesterol, and then followed by the fibrous and lipid and also calcium. And the macrophage, the performance is very poor, likely due to the very small object. So in our evaluation metric, we need to have an overlap of 80% in area, so that makes it challenging. So the detail of this analysis can be found in the paper published in 2021 in Euro Intervention. So further on, we collaborated with Dr. Van Bielskom and Dr. Raja on the histology validation. So this is the preliminary data showing that the AI-derived percentage lipid and also fibrous tissue correlate very well with the histology findings. So this is still ongoing. So the AI, because of this, we can also calculate the plaque burden. Although OCT is limited because it cannot penetrate the deep tissue, but the AI can use information from consecutive slides and the pre-knowledge of the shape of the media to extrapolate the contour of the IEL. So then we are able to calculate the plaque burden from OCT. And this one has been compared to the IVUS on the same spot using co-registered OCT and IVUS data, as shown in the figure here. So the plaque burden from OCT by AI correlates well with the plaque burden from IVUS. So with this, then we propose a new vulnerability index called lipid to cap ratio (LCR), and the reason is because TACFA by definition is a binary variable, and we think that the risk is more continuous variable. So we use the lipid plaque burden divided by the thickness cap thickness as the LCR. So as shown in the figure here, it can be different from clinical. It can be different from TACFA. For example, by the definition, plaque A has TACFA, plaque B does not. So it seems that the plaque A has high risk, but by the definition of LCR, the plaque B has a higher LCR, meaning that the risk for plaque B is higher because of this large lipid plaque burden there. So whether this one holds true in practice, so we published data recently with Harbin University Hospital. So in the validation of the 915 vessels from 604 ACS patients, we found out that the LCR is an independent predictor for non-cooperative vessel-related event at 2 years follow-up, which was the hazard ratio was 19.13, which was higher than the TAC-fast as expected. But this one remained as the imaging feature. So the true mechanism or trigger for plaque rupture is the mechanical factor. So when the plaque stress is over the strength or the strength of the lip fibrous cap, then the plaque can rupture. So in order to calculate the more direct this parameter, then the coronary imaging can be used to create geometry model, and you will need the plaque composition in order to assign different material property, and using the pressure load to perform the finite element analysis as shown in the figure below by Ives virtual histology. However, it's important to know that in order to calculate accurately the stress, the resolution is very important. For example, this is a simulation study. If the cap thickness is only 25 micrometer, the maximum stress in this case is 36.7. However, by Ives, you will likely get a cap thickness of 200 micrometer because the resolution is not enough to capture the thin cap. And then the maximum stress by this calculation will become only half. So there's a massive error there if you want to calculate the stress using Ives. So OCT probably is better in this perspective for the thin cap thickness. It also shows that the thinner cap thickness will increase the stress and increase the chance of rupture. So using OCT, we propose a methodology to calculate the plaque stress. We call it's not absolute plaque stress or what stress. It's relative plaque stress. It's actually the interaction between cardiac contraction, blood pressure, and also plaque composition. So you can calculate detail every location, the stress, the delta stress, using the combination of OCT and also pressure tracing, including the OFR technology that we developed to get the pressure at every location. Still, this one is feasible, but from imaging to actual material property is still a big challenge, because you can only label lipid plaque, calcified plaque, but the plaque at different stages might have completely different material property. Maybe the talk this morning by the colleague there, for example, flame or polar sensor OCT might help in the future, but currently to accurate model is still difficult. So we're looking to see that whether there's alternative to do this. In order to calculate the strain or stress, you have two approaches. One, you know exactly the plaque composition, cap thickness, blood pressure, and the other one you don't know about this, but you know the lumen deformation over the cardiac cycle and use it as displacement load to recalculate the strain. And this seems that at the superficial layer, they correlate very well in this simulation. So this build the concept of the what strain that we are doing. So let me explain this example. For example, if you have a vulnerable plaque like the red image here, so you over the cardiac cycle you have more deformation in the superficial layer, and this reflects in the difference in the maximum lumen deformation. And this information is actually captured by the dynamic angiogram. It's a hidden information in dynamic angiogram, but it's very subtle change. So if your algorithm is smart enough to capture this small change there, so you were able to quantify, we call it radial wall strain, using this formula. So this is what we did. We integrate into software of a single VQFR, we call it micro QFR. So after the mil QFR, you can just one click, and if the image quality is good, then you get the color-coded map here, co-registered with angiogram. The red color indicates the hotspot behind this, and that means that you have a maybe high. So the area under curve was 0.86. The second study was a simulation study showing that the strain analysis by OCT is correlated well with the angio-based radial wall strain, and it can be differentiated a healthy segment, disease segment. And the recent study with Fuller Hospital showed that the RWS is an independent predictor for intermediate progression. And we analyzed the phase 3 China study population. We found that the vessel, the non-flow limiting vessel with higher strain, higher RWS, we have a higher event rate at 1 year follow-up compared to the vessel without with lower RWS. So ladies and gentlemen, in conclusion, AI-based model for automatic plaque characterization in OCT was feasible and accurate compared with expert reading. OCT-derived lip-to-cap ratio can identify non-cooperative vessel with higher clinical risk in HS patients. Radial wall strain can be rapidly computed from a single angiographic projection for assessment of lesion vulnerability. And RWS has excellent correlation with strand-derived correlated OCT by finite element analysis. High RWS identify vulnerable plaque defined by OCT and is independent associated with intermediate progression. Among vessels with preserved coronal flow, angiographic-derived RWS analysis has the potential to further discriminate risk at 1 year follow-up. And thank you very much for your attention.